morning. My name is Andrea. I am an occupational therapist. You can see from my credentials that I also have my master's degree in social work. I was an OT first, and I never stopped being an OT. I went back to school and continued to practice OT, and I am a licensed social worker, although my first capacity is an occupational therapist. The most common compressive neuropathies that I see in the clinic are carpal tunnel syndrome and cubital tunnel syndrome. There are others. You have the ulnar nerve compression at the Goyen's canal, which is in the wrist. It's less common. It's usually compressed up in the elbow, which is the cubital tunnel syndrome. Cumulative trauma, things like trigger finger, very, very common trigger finger, and De Quervain's tenosynovitis, lateral epicondylitis, the bane of everyone's existence, including mine. You're nodding your head, yes, you know what I'm talking about. It's a very difficult condition to treat, and there's a lot of different opinions out there, professional opinions, not a lot of consistent research on lateral epicondylitis. I prefer to call it lateral epicondylosis because by the time I'm getting that patient, it's no longer an acute inflammatory situation. We're talking about a sick tendon. So I have my own opinions on that. We'll see what the slides say. If you have any questions or comments about tennis elbow, I'll be happy to talk about that with you. Traumatic injuries include fractures, crush injuries, and another exciting one, CRPS. CRPS, are you familiar with what that stands for? CRPS? Yes? No?
No.
CRPS is chronic regional pain syndrome, formerly known as RSD, reflex sympathetic dystrophy. They've changed the name over the last, I don't know, 5-6 years maybe. It's a chronic pain syndrome, and it's also difficult to treat, and I have some good experience treating that population too that I'd love to share with you if you're interested. How familiar are you with carpal tunnel syndrome? Very? Okay, do you know the basic anatomy about it? Median nerve running through the carpal, everyone has a carpal tunnel. Whether or not you have the syndrome is the issue. A lot of people come into me, they're like, I have carpal tunnel. I'm like, so do I. The median nerve gets inflamed, overuse with the tendons, sometimes happens after a trauma. I see it after car accidents, banging that hand on the steering wheel, on the dashboard, and just that trauma creates the inflammation to the area. I see it after wrist fractures a lot, all of that inflammation, so it's not just the repetitive stress, which is probably what you're seeing a lot, but I also see it from car accidents and trauma. Did you have a question? No? You know what the median nerve supply is. I will occasionally get someone that's so textbook where they tell me it's my thumb, my index, my middle, and just a little bit on the ring finger, but primarily people complain about the first three. You know that these people have numbness and tingling. Perhaps some of you in here have had or have carpal tunnel syndrome. People complain about it at night. It wakes me up at night. It wakes me up at night. I cannot drive. I hear a lot about driving. It's the holding the steering wheel in that flexed position like this. So driving, sleeping at night are two of the biggest complaints that I get pre-op if I'm treating conservatively. Clumsiness and weakness, I drop things all the time. I can't feel this in my hand, and so I drop it. You also see it with the systemic causes. I think that that's helpful to point out. This is something I kind of have learned along the way as a hand therapist. You'll often find concurrent diagnoses with these. Diabetes, RA, gout, hypothyroidism. I didn't know that. I actually learned that my mom has thyroid disease, has a history of thyroid disease, and she developed it in both. And I told her that she needed to make the most of my college education and go to one of my hand surgeons for the surgery. So she did, and he was the one that told her that it was possibly related to her thyroid disease. So I don't know, I thought that was interesting. And pregnancy. So many of my friends, when we were all having babies, would call me and say, I'm getting it, and what do I do so I don't have to go to the doctor? I don't have time to go to the doctor. Same thing, we talked about that. risk factors with the construction workers with the big tools that vibrate a lot, the highly repetitive work, the keyboard use, prolonged forceful gripping. I mean, that makes sense, right? Because we're working those flexor tendons, and those are the ones that run through the carpal tunnel with the median nerve. You know this already if you know about carpal tunnel syndrome. This is not right. This is right, neutral. You want the forearm to be in neutral. So the gel pads that they sell for underneath your keyboard, you know, probably a lot of you have them. Those are good. The gel helps to absorb the shock in lieu of the wrist banging on the hard desk. And those will promote a more neutral position of the wrist instead of too much extension or flexion, which you don't want. Another example, the repetitive gripping, the gripping and the force. You're probably familiar with the test that the doctor runs. The one that I want to point out on here is the ruling out of the cervical spine problems. The doctors are spending a couple minutes with patients, right? When patients come to me for an eval, they're there at least an hour. I do a lot of in-depth interview to learn more about that specific patient and what they use their hand for. If someone comes to me with bilateral carpal tunnel syndrome, I'm having the physical therapist rule out cervical spine. Because so often, especially, both is a red flag for me. When I say rule out cervical spine, so the physical therapist is running them through range of motion and upper limb tension testing to make sure that the numbness is not, and paresthesias, the tingling, are not exacerbated by changes in position of the neck. If they are, I'll finish my eval, but I'm on the phone with you and I'm on the phone with the doctor to see if we can get someone to just check the neck. Because what's the point of treating them here if the root of the problem is here? I'm wasting your time, I'm wasting your money, I'm wasting the patient's time, and it just gets to the root of the problem much faster. So I think that's an important thing to point out. I've learned that along the way too. EMG, always, that's going to tell you where, what level the compression is. Okay, so conservative treatment. One of the surgeons that I work with consistently always prescribes the B vitamins. I don't see it from all the docs, but I know one of them in particular always prescribes vitamin B6. I don't see the steroid injections too often in carpal tunnel syndrome. But I see referrals from mainly from one referral group. So I don't see them doing the injections. That's not saying that other surgeons do not. It's just not my experience. I see less and less conservative, and I see more and more surgery now. When I do see people conservatively, I always recommend splints. I like to make them myself because they fit people better, and then we're not dealing with this is too big, this is too small, let's try 5 different things, let me just make it and get it over with. A lot of times people have them before they come to me though, because they're getting it at the doctor's office. Night splinting is the easiest because that's when we all want to sleep like this, all curled up and comfortable, and that's why you're waking up at night because you're in this flex position. A lot of times, if the person is comfortable and functional, we'll splint them while they're driving, because remember the driving was an issue. That's pretty self-explanatory. I don't see people for a long time conservatively because they tend to get better right away with the splinting and the resting. I don't do a whole lot of exercises because we don't want to exercise this too much, right? Because that's just going to exacerbate the problem. Oh, look, custom-made night splints. There we go. We just talked about the gel pad. You know, a lot of the keyboard issues. Surgical indications. They're in worse shape because they waited too long, and they continue to do the things that were aggravating. So they need to have surgery. 2 different types. You're familiar with the 2 different types of the release? Yes? No? Yes? Okay. I see primarily the endoscopic. The surgeon's group that refers to me primarily uses either the 2 incisions, and then one of the surgeons uses 1 incision. I've seen them both in the OR. Like a 4-minute procedure, it boggles my mind. Lots of scarring issues, even with the endoscopics, in the palm and right here in the crease. I do a lot of education about scar management. I don't worry so much about strength. I'm a swelling control, range of motion, and scarring issue kind of therapist. Let's get rid of that stuff. That's the stuff that I want to see people with right away. And then that strength usually comes back in time if they are doing heavy, if it's a worker that works in construction or something like that. That's a little bit of a different story because they need to have that strength to return to work safely. And so I'm acutely aware of what they need to do when they go back to work. That's all part of that evaluation process and talking about the things that they need to do at work. This is important, and I talk to my patients a lot about this at eval. How long were you having symptoms before you had surgery? 6 months? Then don't expect to feel good until you are 6 months post-op. Okay? The longer you wait before the surgery, that's about how long you should expect to feel somewhat normal.